Huddy. This is Mercedes Byrne-Klug with the University of Iowa School of Social Work. Welcome to Nursing Home Social Work webinar series. Today our topic is discharge planning, and our speaker is Elise Beaulieu. I'd like to ask people to please hold their questions until the end of Elise's comments. If you want to send a message to me, go ahead and just chat something, and I'll read the chat screen during Elise's presentation. But then, if possible, please hold your official questions after Elise finishes. We are including her PowerPoint with the pages numbered, so if you want to keep track of the number of the slide, if you have a particular question, then it'll be easier for everybody to follow that. Just to remind people, the handout, which is 6 slides per page of this presentation, is on the Nursing Home Social Work resource page. You get to that by Googling the University of Iowa School of Social Work and scroll down on the left-hand side till you see resource page for nursing home social workers, and then our webinar series. And Elise's bio is there, as well as the presentation saved as 6 slides per page, and that is also where a recording of this webinar will be within the next 24 hours. Okay, next slide, please. Right in this queue. All right, and that's our title slide, and then one more slide, please. This is Elise. She's over 25 years of social work practice experience with older adults and with persons with disabilities in multiple settings. She has worked in nursing homes, nonprofit housing, rest homes, and visiting nurses. She is also an instructor. She has taught full-time, and she's lectured at a number of Massachusetts colleges and universities. She has written online courses about aging for the Boston University School of Social Work, including on courses related to suicide prevention, transitional care, abuse, neglect, and mistreatment. She's also provided many seminars on topics like holding, residence rights, sexuality and intimacy in later life. She's chair of the Nursing Home Group, Massachusetts chapter, that produces an annual conference, and they probably have the record for the longest going state conference on nursing home social work country, or certainly one of the longest. And she is also the book author. She has written a guide for nursing home social workers, and this guide is now in its 2nd edition. The 2nd edition just came out last year, and it's a beautiful collection, a lot of practice knowledge, as well as insights about working with individuals, families, and team members, and then a lot of factual information as well. She received the Boston College School of Social Work's Distinguished Alumni Award for 2013. So congratulations for that award, Elise, and we look forward to hearing what you have to say. So we'll move over to your presentation and look forward. Thank you.
Thanks, Mercedes. I hope everybody can hear me. If there's any difficulty, please stop. I want to thank all of you for attending the seminar, and I want to thank Mercedes particularly for her the opportunity to present in this fashion and to so many people at once across the country. It is really, it's a lot of work, as I well know, and it's really an honor. To get into our topic, I know some of you are very thoroughly experienced in the art of discharge planning, and indeed it is an art. I also know that some others in the group have more limited experience. There are, however, many common threads that we all share, and I see the seminar as identifying the overall process of discharge planning, as well as the unique complexities of the practice of discharge from nursing home settings. As nursing home facilities, we are often addressing the challenges for discharge, even more so than hospital settings. Indeed, hospitals refer patients that they cannot directly discharge to nursing homes so that we can take care of them until they are ready for discharge. So, given all of that, let's take a look at our learning objectives, which are on our next slide. Give me a coordinate here. There we go. Oops, I skipped one. Sorry, did it twice. There we go. Let's go back to the objectives. By the end of the seminar, you should be able to understand the overall concepts of discharge planning in a nursing facility, identify current key transitional care programs, identify protective and risk factors associated with discharge planning, understand the role of self-determination in discharge planning, and understand the role of post-discharge follow-up. I started out with the MDS 3.0 because this forms the driver of many aspects of care. The MDS begins our assessment process to determine discharge by asking questions that trigger responses about it. These help minimally frame our plans for the person. We're mandated to ask the resident, do you want to talk to somebody about returning to the community? By this question, in essence, we are looking to provide choice and preference for individuals in nursing homes. Think about discharge. Regardless of how difficult this question seems to be for us to ask, it's important that the social worker and facility have a mechanism in place to ensure that the record reflects that a decision has been conducted and the outcome of the discussion that's evidence. Usually that's in the social service notes. You could actually set a section up in the history if you wish. That's what I've done in some of my facilities. So the history actually reflects whether or not they're going to be long-term. That's helpful. Final question in section Q of the MDS 3.0 asks whether a referral has been made to the local contact agency, the LCA. And should know their local contact agency and try to utilize this resource as much as possible. We can return to this section later if people have specific questions. Overall, if we look at transitional care or people that are in the process of discharge, we want to know how many people are actually doing this from nursing homes. How many people are actually thinking about leaving? Well, our next slide. Facilities are discharging over 30 individuals a month. That's a lot of folks. Some aren't discharging that many. Across the nation, there are approximately 750,938 actively planning a discharge from a facility. When you about the original inception, long-term care facilities were looked at as being permanent placements for people who were admitted. Even the resident indicates that most were not a temporary health care place, but a long-term home. Indeed, what we do, for the most part, regulations are geared for folks staying long-term. The short-term stay focus can be confusing roles for some of us at times. In the survey, though, almost half of the respondents said that their facilities had short stay focus. The reason many factors has created institutional settings, one that is both long-term home and that provides temporary, albeit lengthy, rehabilitation care. It's the rehabilitation care that has continued to change and challenge the face of nursing facility care and create a duality of a hospital-like care with a long-term home-like atmosphere in the nursing home. We have over 1.3 million individuals in nursing facilities across the country. From facilities, approximately 2 million residents discharged every year. However, we can expect this number to continue to shift as the numbers of older adults increase. What do our older adults mean in our environment? Perhaps we can say it means job security for us. On the other hand, we have many competing issues. Needs for short-stay people is important because of the sheer numbers of people projected to be in the vulnerable age group. In our current environment, those over the age of 65, 1 in 5, are receiving care in a nursing home. And yet, all of this care costs enormous amounts of money. Between 2002 and 2004, 50 states have implemented policies to control Medicaid costs, and because Medicaid is the largest payer of long-term care, have reduced or frozen payments. 50 states have implemented policies to control prescription drug costs. 30 states have reduced or restricted eligibility. 30 states have reduced benefits. 2 states have increased co-payments. In 2004, there was a growth rate of 9.2% for Massachusetts in spending on Medicaid and 12.9% for the federal funding. All this means, and who really cares? Well, increasing numbers of elders are expected. Their anticipated need for care and rising costs of this care in the nursing home are on collision course with the resident, the family, care providers who are in the middle. While we reframe some of our residents' continuum of care into home care, such as assisted living agencies, these resources will probably be stretched very thinly in years to come. Process, at the same time, has been rather ignored. And it's particularly been ignored from the perspective of the SNF. But as we can tell, is a game changer. We're all part of transitional care. The person noted that we are looking at more people in the aging group. And we're also looking at a stretched financial system that an older person is, and the likelihood that he or she will enter a nursing home sometime before death is approximately 24%. This means that there will be many transitions. The objectives and focus is to lessen long-term care in nursing homes and put greater access for community care. The focus that transitional care be successful is not without problems, however. And how do we get all of this to work? Let's look at current transitional care. For the aging population, we have a changing healthcare system, one that's going to focus on less institutional care and more on community care. Because we are, in essence, changing the care formula or increasing short stays with the end goal for the person to return to his or her home or an assisted living center. As a person moves through or transitions through the care system, people can run into difficulties. For example, a woman who was treated at the acute care hospital level was transferred to the step-down unit. In addition, their failure to provide complete medications in this internal switch. She had hypertensive medication for 4 days before it was discovered. Is it usual? No, not really, say enough. Let's look at where the challenges lie. Our knowledge of systems and the need for thorough communication aids in making these shifts go more smoothly and completely. Let's look at where some of the glitches happen. Systems-level barriers is institutional separation. Like silos, we exist in our own units without information connecting from one to another. We just in our little photograph of these little silos. Folks in Iowa perhaps are more familiar with those in other states. Several barriers can take the place both within an institution as well as between different institutions. Each institution is its own entity. When you see a hospital, you've seen only one hospital. It's unique and has problems and solutions that are individual. Within institutional settings, communications between members of the same discipline, nurses communicating at shift changes, technicians communicating with nurses at changes in patient status, nurses communicating with physicians, and coordinating with patients and families, social workers communicating with families, patient residents and staff, district planners communicating with the community resources and the planning team. All of these communications are places where the ball is dropped. As anybody who's known playing that game telephone, we know that simple words can be dropped or forgotten, and all of a sudden the message is totally different. Between institutional settings, communications become more abbreviated, and lists of importance can emerge. Think of, for example, the information that you receive from one hospital. How is it similar or dissimilar from the information that you've received from another hospital? How easy is it for you to find the diagnosis, medications, or other pertinent information? Is extraneous information you don't need? Nurses often complain that they don't get the information they need. For example, a newly admitted person in one facility I was at was being treated with an antibiotic, but wasn't an end date for the antibiotic in the discharge note. So they had to call back to the hospital and say, when does this medication stop? Family involvement is not really ever noted, and certainly not contentious issues oftentimes from certain hospitals. Hospitals are better at it. Let's look at the laundry list of system-wide barriers. Care systems are poorly coordinated overall because of payment systems. Once discharged, the responsibility of the institution is ending. Once the person passes the threshold or the airlock of the next provider, you kind of say, job is done. There's a standardization forms and processes that make finding pertinent information difficult and time-consuming. Communication between hospitals, nursing homes, community providers is often shorthand pieces of information, and this leads to suppositions and, of course, the suppositions mistakes. Families can be resources for identifying gaps in the transition process, but this places undue burden upon them. At times, they are not readily available. Inconsistencies and deficiencies in the system include inadequately preparing for the next care system. There is here to ensure patient caregiver involvement in creating a fully understanding treatment plan, conflicting advice for illness management, the ability of patients and caregivers to know which provider is responsible at any given time, reach the right provider, and repeatedly leaving follow-up or coordination assistance on. First-level barriers. I know my own setting. We all have our own settings and what information we need in order to care for our individuals. What we don't know is the form in which the next setting needs that information or what is desirable in caring for the individual. If information is available, we might not be able to provide it, leaving the next provider in a position of asking the person for the same information yet again. Of information is one way to help alleviate this. Communicating with the next setting is another. It's helpful to ask what the next agency needs before the person's discharge. Being accountable for the information is also an important step. From the medication to social information to the care of open wounds, knowing if a person has a PICC line, have the X-ray and the length of the PICC line involved in the transfer is all important to the next caregiver. Think of next steps. Referral. What does this information convey? Are you finding enough information for the next caregiver? For example, if the person you're discharging cheats on his or her diet, do you insist in your referral to the home care agency? How to raise social problems with the family or potentially problematic discharge? Personal barriers. Communication between providers is an essential component of effective care transition, especially during handoff at admission and discharge from all institutions. Barriers to effective transitions include cultural, educational, language differences, provider fatigue, time constraints, intervention, complex medical conditions, ineffective communication, incompatible information systems, lack of privacy, Interpretations of privacy concerns related to HIPAA. That's been a lot of times people misunderstand HIPAA, and HIPAA allows us to provide information about the person that we're referring as it concerns the care that they receive. So we don't give every single tiny morsel of information to the next person, but if it does pertain to their care, it's very important that we do provide that information. For example, if somebody has had a post-traumatic stress disorder related to a sexual rape, we need to share that information if it's impinging on their care for the next provider. Just post-traumatic stress is probably inadequate. How would you convey that information in a personal and yet helpful manner? And it's very important. Illiterate writing. We can begin there. Sometimes you're looking at material that you've received from another facility and you can't read their writing. That's not helpful. Non-standard abbreviations. It's not surprising that when 2% of seniors report that their health has suffered due to poor communication from among their providers, and that has happened to them. Acute long-term care support is often poorly coordinated among these reasons cited above. Care beneficiaries comprise 46% of hospital admissions. Communication problems can have a substantial impact upon quality and cost. Hospital to rehabilitation to nursing home and then home again. There might be as many as 20 different specialists involved in a person's care during one bout of illness. Think about that. 20 different specialists. Talking nurses, physical therapists, occupational therapists, social workers, care managers, all providing treatment within his or her own area. Models in the hospital, we can see what helps. It helps to have a structured support transition with everybody on board. I'm going to talk about that. I'm also going to talk about the impact that has for the nursing facility planning. Summary, what we've talked about so far is we can see that by the early statistics, there's a great shift in long-term care to accommodate residents who are in facilities for short-term rehabilitation stays. At the same time, the frail are returning to the community where they're more likely to revisit a healthcare facility, whether it be an emergency room, they will visit hospitals, and sometimes even come back to the facility again. Skills are needed both in manipulating and directing resident stays. Charges to maximize recovery time and available long-term services in the community. Discharge planning requires a complement of skills that are very unique to social workers and of what the facility offers as well as the community services available. We include families. We want to include the resident's self-determination to attain freedom, dignity, feelings of self-worth in the least restrictive environment. We want to support discharges. At the same time, we want to be aware of the frequent flare syndrome that's occurring. Refer to that as the who comes and goes into the facility, goes into the hospital. These often have multiple hospitalizations, placements, and returns to the community. It's the social worker who needs to address the pros and cons of multiple placements. And we want to take a look at some of the models that are currently being used at the hospital level. And remember, I said earlier that we really don't have anything, so we're going to have to take a look at what we can use in the nursing home. But I'll start off by what they're doing in the hospital. Comparison of transition models, the top models that are being used across the country. The first one is Care Transitions Intervention, and this is a Coleman model, and it comprises of 4 pillars. He calls them 4 pillars of care transitions and intervention. The first is medication, education, self-management. And the concept here is that so many people don't take their medications regularly and use medications well. It's really important that we train them to do so and them be responsible for this. Second piece of his transition is the use of a personal health care record. And the third is primary care and specialist call to the physician follow-up appointments. And the fourth is knowledge of red flags about healthcare crisis and the call and a need for a phone call to the physician. They found that this model has evidenced great success in reducing hospital admissions because of greater compliance with medication and post-discharge follow-up. This model, again, I want to go back to the personal health care record for a moment. The personal health care record is where people list themselves. This is something that they hold and that they complete themselves. They list their diagnoses, list all current medications, and the people that the healthcare providers that they're working with. And that, again, the whole concept of this is to help people be self-empowering and to take a positive, proactive role in their health care. Second one is the transitional care model. That is with Mary Naylor and her group. It's interdisciplinary. It includes both comprehensive in-hospital planning and follow-up home with the model aimed at improving continuity of care and involves the patient, the family, and caregivers in post-discharge needs. CTI model, there is follow-up in the community with transitional care nurse who maintains contact post-discharge by phone. The BOOST model also is one that has shown very good results. There's a medication reconciliation component to it, just assessment of preparedness and feedback. Again, it's focused on medication and knowledge of this and empowering the resident or the patient, in this case, the caregiver, with education. And again, the third piece to this is a post-discharge follow-up. Okay. Programs that we just talked about address some important facts in discharge: medication, diagnosis, information about care, and follow-up. Putting these practices at the nursing home level can help to foster greater discharge success. However, for some of our nursing home residents and individuals, we need to think more broadly about transitional care needs. Older nursing facilities are more likely to have additional challenges, such as less than adequate home settings, poor social supports, or greater physical or mental challenges. In fact, that is why many of these folks go to a nursing facility and on a direct discharge from the hospital. For the home individuals, we need to expand our thinking to include additional factors that, when combined, help to determine our interventions. Okay, so we're going to move to the next slide, which is the environment. Some of you may be familiar with this concept, the person and environment. These are areas that are broken down into strengths and problems by specific area. Interest areas can represent the areas that affect discharge. Community sources, mental health, medical diagnoses, personal characteristics. Example, personal characteristic can be living alone, which can be both positive and negative factor. If the person was previously independent, that may indicate that this person his illness or her illness is less acute and less chronic in nature, able to be resolved at the nursing home stay. At the time that the person was living alone and poorly managing, then alone post-discharge may be a risk or detriment. Family caregiver, what is the status there? And certainly we want to take a look at payment and insurances. Payment is sometimes a major issue for folks. Run into, in my practice, people who don't want to use a nest egg. And that can cause some problems with discharge if they need services. You kind of say to the person, well, you said a rainy day, and now it's time to use that. It's time to use that nest egg. So that's another piece of pays for what and how. These qualities form a matrix of information. In a way, both protective and risk factors. The protective of a transfer is an accurate handoff of a complete set of information about a patient's or resident's or an individual's status and care plan, and the transfer of authority and responsibility from one set of providers to the next. And to do this, we pull together a group of elements that can be labeled as either protective, a strength, a need, or risk. Over the years, the literature has provided us with a number of qualities to help formulate that. Protective factors. Studies that the literature has determined to create that indicate a protective quality for successful community living. These are self-explanatory. For example, why would a fracture diagnosis be a protective factor? And this is because a fracture is generally an acute ailment, and there's a reasonable assumption of recovery or even full recovery. With a payer source, one is likely to have been in a facility for less than 100 days, and this is a more supportive quality to discharge than being in the facility longer. A person with a fracture diagnosis without a dementia diagnosis lives with spouse, has an involved supportive daughter, in Medicare, is typically a good discharge candidate. Developed disabilities can be a more protective factor in that there are often more community supports offered. Eligible people, those people who have Medicare and Medicaid, are also more likely to have community resources in different parts of the country, making them or helping them to more likely succeed at discharge. Age, people who are over 85 are more likely to have difficulty or have a bigger risk, simply because they more likely have chronic ailments. We can go down the whole laundry list, but I just want to skip to cognition and dementia. Something that is really key for people going home. Having worked in housing, one of the biggest things the biggest difficulties that folks had was living in a setting when they had cognitive issues. Now, a long-term resident, 7.5% of people in nursing homes have an okay memory. Short-term memory, only 27% have an okay memory. So I want to look at our DIM scores as looking at and asking whether or not these folks are doing well if they have to go home alone. 3.2% of cognitive problems impact discharge planning. So keep that in mind. Almost 3/4 of folks who have cognitive problems, it can affect their discharge planning. Okay. Self-determination. Seeking balance between safe and being in one's own environment is often a difficult task, and making informed choices is an important step in this process. There are often strong feelings of the individual as well as the family and staff that can come around this very issue. Some staff weigh in on the side of ultimate safety, as the person's fully capable discharge should not take place. These are distraught over a loved one's desire to return home, particularly if there have been difficulties in the home prior to placement. Regardless of the opinions of the stakeholders, discharge should be a process where all constituents are involved. Down to helping and weighing the risks and determining what is the individual's risk threshold. How does this person going back to the community? Are the risks acceptable, and to whom? Is the individual in immediate or imminent danger if he is or she is to return home? Is discharge planning opting for maximum safety as opposed to reasonable safety? How has the facility tried to ensure risk reduction? Home evaluations help to identify difficulties, training family members, responsible individuals to care or other avenues. But discharge planning is also what we want to do is address all three of those: quality of life, weight, and informed choice. Many social workers encounter barriers to discharges, and I want to just note the ones up at the top. I don't want to spend too much time on them in the sense that these barriers add to the risk of discharge. Without the proper resources, individuals can lack the tools to make their existence safe. These can take this more financial difficulties, problems with access to assisted living centers, as well as caregiver fatigue. How some of these problems be resolved? The knowledge of local and regional services help. You might want to connect or reconnect with the local ADRC, Adult and Disability Resource Center, or Area Agency on Aging. The local resource person is to assist you with new or additional resources. I've run into many people who really don't know some of the resources that are out there, and hospitals are notorious for this as well. Many states are developing programs, for example, that specifically address individual issues. For example, in Massachusetts, they just started, or they've had going for, I guess, a couple of years now, onset head injuries, and programs that take people out of nursing homes and put them into group homes where they are able to live in a less restrictive environment. But the qualifications are that they have an adult onset head injury. Also have here a program called Caregiver Homes where are paid to take care of family members. So we're asking what resources are out there, because they're popping up, and they are allowing more people to live in less restrictive environments. So I'll go to a case example. I want you to meet this is Janet R. She's an 87-year-old childless widow who has been at Martin Rehabilitation and Retirement Center for 33 days for treatment of a fractured hip. She has an apartment in a rural community where the resources are limited, has only Medicare. She is eligible for Medicaid because her monthly income exceeds the current level limits. As a former teacher, she has some devoted friends who visit regularly. One friend noted that Mrs. R's apartment was extremely cluttered. Her PHQ-9 score was an 8. Cognition on the BIM score was 12 out of 15. It's very slowly with a walker and has stress incontinence. An insulin-dependent diabetic that manages herself. She makes her own insulin. And the nursing staff have noted that she occasionally cheats on her diet. She is determined to go home. Cute little lady. Okay, let's take the protective factors first. Okay, so Janet R., okay, we just heard about her. She's 87. That's protective factor. She's childless. She's widowed. She has been at the rehabilitation center for 33 days. Protective factor. She's treated for a fractured hip. Protective factor. In an apartment. I mean, she's not homeless. And she's living in a rural community, which is a bit of because there are limited resources. She has Medicare, but there indicates that she hasn't been in the facility that long. She's eligible for Medicaid because she has a monthly income that exceeds the current allowable limits. So, she has financial resources. But it's friends who visit regularly. Friends noted that her apartment's cluttered, but that's not a positive factor. Her PHQ score is an 8. That is a positive because it's a 10. Over 10, it would indicate depression. So the score is an 8. So it's sitting at the edge, but it's still under 10. Cognition on the BIM score was 12 out of 15. She ambulates herself, although it's very slow. She manages her diabetes herself. Actually, we could add that she's determined to return home, which is certainly a positive. They're all the strengths. We'll look at some of the challenges or risks that she has. First of all, she's elderly. She's 90 years old. She's childless. She's a widow. Days works well for her, but it also speaks to problems because it's been a bit of time for that fractured hip. She lives in a rural community where there are limited resources, so that could be a potential risk. She's eligible. Again, disability works both ways. She's ineligible because she has too much income, but does she have enough income to provide her with the service that Medicaid system might offer her? We don't know. Her apartment's extremely cluttered. That could be a negative. She could trip and fall. And her PHQ-9 score being an 8, I can consider that a positive. It relates very, very slowly. Incontinence can be an issue. And finally, cheating on her diet is a problem. All of those, we've got risks. So what are them? Okay. This is actually, I'm labeling what we oftentimes do anyway. And I know some of you will say, okay, I do this anyway. And good, I'm glad. I think it's very helpful for us all to do this. Let's break it down so we know exactly what we do, how we arrived at our decisions about discharge planning. While Mrs. certainly has strengths, she has some deficits that can be defined as risks. Should she remain in the facility or should she return home? What's the services is she likely to need? What do we know about her and her environment? We know that while her location is rural, there are some advantages. She has a visiting nurse. There's a home health aide, a homemaker. There are OT and PT. Not depressed, but she certainly has some signs and symptoms. Her 7-8. Possibly a social worker to visit in conjunction with the VNA. Friends who can make their commitment to help with her and could clean her clutter. That could make that deficit go away. She certainly could have equipment. She'll need a walker, possibly a wheelchair, perhaps one of those 3-way commodes, delivered meals if they're available, stream service. She can afford a lifeline or other emergency system. And if friends or counsel on aging to help with transportation to a medical equipment or medical appointments, that would be very helpful, or even church affiliation. Information, do you see more risks or strengths? And important. How do your staff see this issue? Would you be looking to discharge her? And your concerns be? And might you utilize some of your resources to make it safer for her? Practice. I can see risks and protective factors speaking to our discharge planning. You're using some of this already, but not necessarily labeling it as such, as I mentioned before. We can basically determine what is best practice by understanding what is the individual resident family action and a successful outcome with the discharge plan. That the person returns to the community and lives there safely, along with his or her needs being met in a manner consistent with the overall plan of care. This is within our perceptions. Respectful with others and for others in our discharge decisioning process. And we want to be aware that it should fall into common sense and professional judgment. financial, emotional, physical, environmental, all factors that are blended in with the strengths and needs, making all concerned with the introduction of discharge at the very start of someone's admission to a nursing home. The social worker is a key component in the process. All constituents should be involved in the decision-making process, and no one person or no real person outside the individual themselves should be the person who makes the final word. In other words, if a person wants to return home but the family member doesn't want this because they fear the person falling, does this mean we never let them go home? How do we address that? I'm giving you something here that you can get. This is from the Louisiana Healthcare Review, and it can help process a risk. It can be another way that we look at discharge and risk assessment. And they suggest it be done 2 days before discharge. You can get this online, and it's kind of pretty colors. It's an assessment. It's a big tool that looks at a matrix issue. It doesn't look at strengths. I think it's really important to look at strengths and also certain kinds of deficits. Clinician can trump almost any disability. If a person is able to make good decisions and to direct others, then he or she can self-advocate. To give an example here, I discharged a man to live alone who had an unusual neurological disorder that would cause his eyes to suddenly shut. Actually have visual paralysis for 3 or 4 minutes at a time. He was a man whose niece had offered to take him home with her, but after consideration, he refused and was determined to live alone in his own environment. The rehab team was very concerned about this decision and actually considered discharging him AA, medical advice. However, his insistence ultimately went home, and he did. One of the things that he had to stop doing was crossing the street. That was a bit of a problem. Things really, young discharged people who are quite frail, and that's important to take into consideration. But matrix here, it can be a helpful piece. Attention. 3.9% of social workers report that their facility supports their role in discharge planning. Now that's good because we need everybody to be on our team when we work with discharge planning. It's all empowerment. This incorporates everything from the physical therapist to the bookkeeping department. So we need to link the family and the resident with these resources and supports to outside resources. We need to build strong, respectful links with community resources that can be valuable in coordinating our discharge plans. Mutual trust and honesty can help prevent complications. Strong stand about a resident's need for a few more days of time is also helpful. However, providing a reason why this is necessary is probably even more helpful. If a daughter won't be in the area, then share this with the team and help provide realistic alternatives. It's always interesting how family members decide to take a vacation just about time the person wants to be. I've had this happen multiple times. Creative options are also exceptionally helpful in our busy days. Social workers can provide resources to residents and, if competent, encourage them to take responsibility for their own discharge arrangements. I will talk about this for a moment. I ran into a social worker who was working with some incredibly busy facilities. She was the only social worker, and she had people who were homeless. However, they were able to take charge of their own future, and what she did was she set them up with a phone and a desk, and they made their own phone calls for housing. They made their applications, and in turn, they were very much in charge of their own destiny. And I think workers also need to remember that empowerment is a very powerful tool, and giving people responsibility for tasks and helping do that is just as important as it is for them to get dressed and on their own. So we need to remember that people do their own phone calls. Families can also take charge and responsibility for making arrangements for a discharge. And as long as we make sure that the task is something that they can accomplish and that we have a way of following up, I think that we need to encourage that more. Areas of social work is mediation. When a resident is in a nursing home, there can be a healthcare crisis that affects multiple relationships. Residents are in pain when they've finally reached us as they go through the system. Sometimes residents and families and facility staff can be conflictual. Social workers can work hard and help make this happen. So work and build and mediate different circumstances. Okay, Amy. Gathering the team in the planning process is absolutely key. Many adults and families come to nursing facilities exhausted, as I noted before, and when they come there, you say to them, "Oh, well, we're going to do a discharge planning meeting," and they say, "What? We just here." But time is the essence in healthcare. People often make good gains in 1 to 3 weeks, and the clinical staff needs to be prepared as the ultimate goals are going to be. Developing a 72-hour routine discharge plan is very good policy, and if it's possible, try to stick with it. That's the state and helps everybody focus on tasks. You discuss discharge throughout the stay. This can be done at meetings, informal discussions, and it helps to eliminate surprises. You push your rehab team for their dates and progress. Nothing worse than having a rehab team say, "Oh, yeah, in 48 hours, so-and-so is no longer eligible for all services." That doesn't give anybody enough time, so you really need to stay in touch with the rehab team. Explore agreements and disagreements is also important. If there's a nurse who express concern about a resident's safety at night, or concern about diabetic teaching that hasn't gone out, if somebody has poor vision, or actually a person on the team who promotes quick, formulated discharges. Worked in a setting where the director of nurses pronounces "discharge tomorrow." What? That doesn't work. Community planning. It may seem simplistic, but it's always important to clarify who's going to complete what task. Identify who's in charge of making that. The discharge is set for blank pronouncement. We need to know who is going to make that decision. So it comes from sometimes it comes from nursing. Sometimes social worker is in charge of that. If that's involved, there should be follow-up to ensure that the task assigned or task they accepted is completed. One of the things that's big nowadays is who's going to make the primary care physician appointment and who is the transportation for that. Is that treatment transportation arranged? When is the organization returning home? How will the person get into the car? Is there physical therapy training to get into the car? Family needs to be in the information loop for each step so that they can be prepared as well. Some of you who've worked with discharge planning know that anywhere along the line, those can be problematic. There's a relatively new piece to discharge planning, which I wanted to include in our presentation today, and it's called the face-to-face encounter form that are required to certify individuals for home care services. Started last year. Some should be familiar with them, although I think some are more familiar than others. The treating physician or the nurse practitioner needs to sign them and date them so that they person. There needs to be a discharge summary of the services provided and a further rehab needed, OT, speech, etc. And in particular, the status of homeboundness. In other words, that person needs to be treated at home and they cannot leave the home setting to do other things. So that makes them eligible for physical therapy or occupational therapy or VNA services at home. I suggested that facilities design and use their own forms. Many care organizations are having facilities sign their forms, and this seems odd because it's the treatment facility. Our nursing homes are signing that this initial need for service is included. However, CMS does not make requirements about the form per se as long as it includes the key elements. Multiple pages are facts. So I want to show you the encounter form, and that helps. This is the face-to-face encounter form. As you can see, there's name, date of birth. We have when the person's seen. We have what they need at home. So this is a very simple form. If you want, you can grab it, stick your letterhead on top of it, and fill it as you need. So it is available. So if you need to do that. Okay, I want to go here. Excuse me, I'm getting a wheel, which means it's, oh, here we go. All right. Well, let's go back here. Okay, discharge follow-up. I will talk about this very briefly. 30% of social workers make follow-up phone calls. That means that 70% of social workers don't. Why do they make post-discharge follow-up phone calls? You want to know the status of the person and his or her well-being. You want to see if the services that were planned are coming as planned. You want to see if there are any unmet needs. You want to show concern for the person and the family following a stay in your setting. And it's just basic good PR. So I still recommend that you put that as a part. Okay, discharge challenges, the good, the bad, the ugly. If you don't make post-discharge follow-up phone calls, you're not going to be in the loop to know when things go wrong. Discharge, I'll give you an example. This past Sunday, I had everything planned, everything lined up. I had faxed everything the Thursday before. I thought we were all set with all the equipment, which included a hospital bed, a Hoyer lift, and a wheelchair. Came to find out on Monday morning that none of the equipment had arrived, and after the person got home, even though it was scheduled for Saturday. I was astounded and very appalled because the family needed it needed the equipment, and it wasn't delivered as scheduled. But I would have known that had I not done my follow-up. Improving discharges and transitions of care, improve your communication, implement electronic medical records, have points of accountability in both sending and receiving people's information. Increase case management. Include the role of the pharmacist, particularly around medication reconciliation. I've been doing a lot of that from the hospital into the nursing home as of late because the hospitals discharge people with far different meds than they came in, and did the performance measures. And you could probably use the KQI. Okay, I've got 2 minutes left. I want to just go to my summary. I'm going to skip this next part because I think that's probably what we've and I summarize. Good discharge planning is essential for increasing short stays. There's a proven transitional care model, CITM and BOOST. The permanent environment, or PI, includes an inclusive model, protective and risk factors. include self-determination and informed choice for discharge planning, and post-discharge follow-up is important to ensure service continuity. Thank you very much, and I'll be happy to take all your questions now.
Very informative and interesting as well, so thank you, Elise.
Oh, you're
anybody, good. If anybody has a question, you called in, then you can put up your hand and I will unmute you. If you are listening over your computer, you can type in a question through that box. We're waiting for people to think. Oh, it looks like Meredith has a question. Let me see if I can. Meredith, doesn't look like you called in by phone, so can you go ahead and put your question in the chat box? And you send it to the host or to everybody, however you want to do it. So go to the right side of your screen in the lower right corner and open up the chat box and then type in your question. Okay. In the meantime, a lot of things I really liked about today's session is that you gave people ideas about different language they can use with their administrators to try to garner more resources for nursing home social services. So showing, especially was taken aback by the barriers to doing good discharge plan. Social workers need time to do community networking. It's part of their job to know what these resources are, and if you're inside the facility the whole time, you're not going to be able to do that as well as if you do get out to go to some meetings or have networking opportunities. I see there's the question for Meredith is, please provide the link or the site for the discharge risk assessment. Okay, I will. It'll be on the National Nursing Home Resource page, and that's through the University of Iowa School of Social Work. And after we finish today, so like in the next 20 minutes,
I'll get that.
But up there.
Yeah.
Looks like a really interesting tool, Elise, so thank you for sharing that Louisiana Healthcare Review tool with us. Jude, I see that you have a question, and let me see if I can, if you call in, let's see. People who call in, I don't see their names, so you're going to have to please type in your question in the chat box. So be Bob and Julie, if you'll type in your question in the chat box, because the users are not associated with the name, they're just associated with a number, so perhaps people register when they called in, I'm not sure. But go ahead and type in the question, that'd be great. I find those of you who need to get off the phone that the rest of this, the whole recording will be available online if you want to re-listen to parts of it or share it with somebody else. Any other questions?
Mercedes?
Yeah.
There was a question here that was written, how to deal with a physician who has a long-term relationship with a family and doesn't see the risk factors.
Okay.
I've had that happen. As a matter of fact, I had a pretty disastrous discharge because the physician was actually friends with the resident, and he couldn't even get out of his wheelchair by himself. And he felt that he could go home and looked at it and actually said, writing the discharge orders, and what are you going to do about it? That's what he said to me. And I said, nothing. I said, you're a doctor, you're in charge. And but I think what you can do overall, that was certainly an extreme example. He ended up in the hospital the next day. But you can do is you can talk with the physician by looking and listing the actual risks and protective. I would start by with the positive factors. This person has X and Y and Z, and here are the risk factors. And I think that ultimately, the question is, what is this charge in some ways serving? Is it serving to prove to a person that can't make it at home? And how great is the risk under that circumstances? And what is the how can you build in the very best recovery of a very risky situation? You can sometimes call in protective services, although it's not always, that doesn't always resolve the issue. But I think sometimes letting people go home and fail is not bad as long as it isn't extremely and extraordinarily risky. So I guess that's my answer to that.
So, if the physician has more power in the relationship, but if you can help frame the status of the person in terms of how you see their strengths and then their risks, how they may be at increased risk of a fall or different things, sort of trying to add a little bit more information to that conversation.
And again, I suggest very much that people start off with the positive, because people are always saying, "Oh, you're negative. You're not looking at the person's real desire to return home." Like in the case of the man who I mentioned earlier, who went home and also promptly. The thing is that failure at home. Even when you have somebody who's doing very well, there are acute ailments that do crop and cause people to fail at home very quickly, and when they look good too. So, are those failure of discharging? And have to back up and review all your systems to say, well, we couldn't foresee this as being a problem. It wasn't a problem here. They were really, really okay when they left here. And we didn't realize that this was going to happen. Because discharge is always a risk. I mean, move from one setting to another is very strenuous and very stressful for people. And, things can happen. But people can do very well. Like my gentleman who's automatically closed without his volition.
A couple more questions have come up. Here's one from Joni. Is the social worker always the sole discharge planner? In our very rural community, we use nursing to coordinate discharges along with social services. It's more of a team approach. But the nurse does the post-discharge follow-up. So, Elise, do you have experience of other disciplines involved with the discharge planning?
Absolutely. Again, when I mentioned earlier that we all have to decide who does what, and it's best doing what too. Time management is of the essence, and if somebody has more time for something, then that's the person who should do it and to be able to follow up on it. I think that in the case where a nurse does the follow-up phone calls, I think that's great. He can review the medications, can review what is physically going with the person, but it's always important to check out whether the services and equipment have arrived, because so often is beyond control.
Mm-hmm. You made a point of that in your case example about the situation in which you thought you had all that equipment lined up, and then you called back to check, and it hadn't been delivered.
I mean, it was a nightmare, and it made me look really awful. I mean, not only did it make me look awful, but it certainly put the person at risk, and the family was very distraught. And what it was the company, the medical equipment company's error. They just didn't have an order for it. And it makes it very difficult when you discharge people over the weekend and you don't have some sort of and that's another thing that you can do, is to have a plan. If discharge and there's a problem, make sure that he has the phone numbers. What happened was that the nursing staff in this particular case, tried to handle it, and they didn't call me because I might have been able to help in some way, but that you want to do. But I want to go back to the person who asked the question, who does what? You just have to make sure that everybody's on the same page with who does what. If you're going to order the equipment, then you order the equipment, and then you follow through with it. And that's important, because otherwise nobody, oh, did you order the equipment? No, I didn't. Oh, well, you were supposed to, weren't you? Write it down.
That is so very important. The thing that occurred to
Critical.
me as you were talking, Elise, is that uh, well, the importance of good discharge planning for the nursing home resident to be successful in the community. The incentives for hospitals and the healthcare systems are rapidly changing, and within a year, there's going to be a lot of people really interested in discharge planning because of the Affordable Care Act and the need
Mhm.
for regional accountable care organizations. And so there'll be a big change in the financial incentives related to care, and part of the success will be those systems that develop good discharge and transitional care routines and options. And so this is an opportunity for social workers for us to roll up our sleeves and really what we can do now, but also ask for the resources that you need to do a good job, because finally the incentives have changed or are in the process of changing, and ears will open in a way that they just haven't opened before. So we go ahead.
The other piece that I want to include in that little caveat is that it's really good marketing to have good discharge planning.
Hmm.
If you are trying to market to the community and you do a good discharge, the folks are going to be happy at the other end. They may not say anything, but they're going to be pleasantly surprised that everything showed up as scheduled. The folks there are so nice. I mean, if you think about it yourself, if everything goes smoothly and then there's a person at the other end of the line that says, "Hi, how you doing? Everything work out all right? Are all your services are in and all the equipment arrived and everything's going well?" That's an incredible PR tool, which can be used in PR language. We do excellent jobs in helping you exit our facilities, so it can be financial P2 that sets you apart from the other facilities in the area.
Good, because good PR results in good referrals, right? It's
Right.
the relationship building of the whole facility in the community.
And Phil's that.
Thank you so much for your time and
Oh,
sharing
thank
your
you.
decades of practice wisdom with us. And I also want to thank you for writing the book on the Guide to Nursing Home Social Workers, the second edition. It's a really very useful book. And congratulations for your career successes and also for your willingness to share your insights with others. So thank you so much. And
Thank you,
we're going
and
to
thank
go
you.
off the air.
Okay, received.
Mm-hmm.